Hi, I'm Katie Allen. I'm a paediatrician turned politician, and I'm constantly asked why change from one of the world's most trusted professions to one of the least. The answer is simple. I want to get inside the tent to help make our future better. Along the way, I've met fascinating people and learned a lot about how the world works. I want to share some of that experience with you, and through my podcast, you'll meet some really interesting people who are helping solve the problems of the world. Reach out to me on socials to let me know who you want to hear from. Join me, Dr. Katie Allen, on An Apple a Week. Hopefully, you'll learn as much as I do. Welcome, Matt. It's fantastic to have Matt Hancock with me on my podcast today, and we're here talking about health. So it's fantastic to have a health secretary online who is able to tell us about the NHS and how it compares with the rest of the world. What are the issues facing this massive employee of people? I think the fifth biggest employer in Europe, I think. Is that right? At 1.4 million.
World.
In the world, sorry.
The NHS is only superseded in size in terms of employees by the Chinese army, the Indian Railways, Walmart, and one other. I can't remember what the other one is, but anyway, it's a very large employer of.
Must have been extraordinary when you were, handed something like that, a portfolio of that size, and that sort of impact, not only on the budget of the government, but on people's individual and personalised lives.
Yes, I mean the thing about health services is that we have an emotional relationship with them, right? Because your most difficult times in your life and your best times in your life are often experienced in a hospital, and so the relationship is not just about policy, important as that is. It's a very emotional one, and I think that's why we Brits regard the NHS with reverence, and it was Nigel Lawson who said it's the closest thing we've got to a national religion.
Yeah.
And the key is to make sure that we keep improving it, and don't allow a deification to freeze it in aspic. And that is the biggest challenge, is making sure the NHS can be as good as it can be when people hold it with such high regard.
I have to say, when I watched the Olympics in 2012, London Olympics, I mean, for someone who's been in the healthcare system, myself as a doctor and on the board of a hospital, I was just astounded that, there was a big NHS bed. We were at a sports, experience. And it was the number one thing that the UK was proud of.
Yes, that's right. And the reason it brings people together is because if you think about it, it's that at that highly emotionally charged time, the nation, through the taxes that they pay, the nation metaphorically comes to your bedside, and the reassurance that that if you get ill, you will get good treatment is incredibly important. That promise that healthcare will always be available to you, and as a conservative, I strongly believe in the NHS free at the point of use, because I think that it binds the country together. I mean, it's also, by the way, really good for business and for employers because you don't have to provide private health insurance as well. So there's lots of sort of functional benefits. Then there's the challenge of making sure it's run efficiently. And there's an endless debate about how efficient it is. But the way I'd put it is that if you look at the total share of our national income in the UK that we spend on health, it is lower than in some other comparator countries. And the outcomes are better in most areas, especially in response to acute events. What we're not very good at, and I think this is partly because we have a free at the point of delivery service, is preventative healthcare, is getting ahead of the curve and saying to people, this is how you can stay healthy in the first place. And so the NHS is too much of a national hospital service rather than a service to keep people healthy, which is something that the insurers has put a lot of time and effort into.
That's fascinating. I mean, in my first speech, actually, that's one of the things that I articulated as I care very much about is how do we move a healthcare system from being an ambulance at the bottom of the cliff to, putting guardrails up at the top so people don't fall off. Yes. But of course, as conservatives, I call myself a progressive conservative, which is slightly different from purely conservative, but, taking new ideas and moving forward, but not fixing what ain't broken is the way I would sort of see myself. But I think, how do you shift all the spending from the bottom of the cliff to the top? And traditionally, preventative health has been, it's simply seen as eat better, don't smoke, don't drink, and that's a long way from a doctor's sort of remit, which is to fix someone's gallbladder that's sitting in front of them, or fix their cancer that's turned up. And there's that sort of 20 or 30 or 40 years of lifestyle factors before they become outcomes that doctors are treating. But people are now starting to see it in terms of not just primary prevention, but secondary prevention, which is once someone comes into hospital, they might have had a fall and they're elderly. Do we make sure we wrap services around them? And the hospital reaches into the home to keep them in homes, keep them at home. And we know that in Australia in particular, the aged care system and the healthcare system are very different sectors. And I think social spending and health spending here are in different pots, but they're becoming more intertwined. And how do we bring those better together so that they're looped up systems? Because one of the benefits of the NHS that we don't have in Australia is we have two layers of government responsible for health. We have the federal government responsible really for primary care and for drugs or for Medicare. And then we have the state system responsible for hospitals. So even though in the Commonwealth Fund, league table, we're one of the best healthcare systems in the world, in Australia, along with the UK, our population gets very frustrated by the political fights and the bun fights between blame shifting and cost shifting between the layers of government, which you don't have in the NHS. But you do have the distinction between social spending and health spending. So how does that work here in the UK?
Yeah, so this divide between primary care and secondary care is increasingly defunct, and it was introduced actually in the UK in 1911, and it was only until I changed the law a couple of years ago that secondary care, so hospitals, couldn't employ general practice doctors, GPs. There was a legal separation between primary and secondary care, but this is ridiculous. There is a continuum of health needs, so all the way from that which can easily be treated in a pharmacy, and we do far too little in pharmacies in the UK. We should do far more, and like they do, for instance, in France, through general practice into secondary care, both elective and emergency. Then, of course, to the great tertiary research and highly unusual healthcare problems, and then to social care. Now, in our system, all of that is under one roof except for social care, and that causes very significant challenges. If you put primary care and secondary care, paid for by different taxpayers, essentially, which is why this different layers of government causes this tension ultimately. I can see why that would be a big problem. We found that the number one solution is high quality data. Yes. If you get the data architecture right, you can actually smooth over a lot of these problems, in particular between health and social care in our case. And getting a decent data architecture is absolutely critical to a health system for the future.
Yeah, and that's what I find very interesting, because digitalisation is coming at speed, and the healthcare systems right around the world have been very sort of piecemeal at taking them up in a sort of simplified way. But on the other hand, I think the population doesn't want Big Brother in the hands of government. And what is interesting through COVID, in Australia, we tried to introduce a COVID Safe app, which was about putting your data with regards to moving about, a bit like what Hong Kong was doing. And there was this massive backlash in the Australian context. And more than that, people didn't take it up because they didn't really trust that government could be trusted. And yet the irony is all we were asking for was, I think, name, gender, date of birth, and your postcode. And it was all completely de-identified. It was in your hands. And yet when that didn't work, some private companies decided to do it, and it all worked beautifully. And you look at the way that we give data across, into our iPhones in order to find our favourite restaurant or to be able to travel very easily somewhere. People trust big data companies, but they don't trust government with big data. The irony of that seems quite extraordinary.
I don't think that's right, Katie. I don't think that's right, because 98% of Brits have given their most sensitive personal data to the state and to the most sort of, autocratic part of the state when we sign up to have our iris scanned for your passport. So people do trust the state if there is a purpose to it.
Right. Yes.
And people are willing to give your iris to the Home Office, iris scan, not the iris scan to the Home Office, just in return for getting through a quicker queue at Heathrow.
Well, let's be clear about that, Matt. I don't think I realised I was giving them my iris scan. You're quite right, but that just shows I have, but I hadn't realised.
Well, I'm sure they're very grateful.
This is the ignorance, though, of what we do with our data, is that if you don't tell people, then they're going to do it anyway. But if you tell people, they won't do it because they're frightened that you can't trust them.
That's right.
If you told me you were giving the iris scan, maybe I'd feel differently. But I'm like, I just want to get through that gate quickly. I don't like the queue. Exactly.
And so there are ways of the government providing the reassurances necessary, because using that data is absolutely critical, not just for an individual. If you turn up at A&E out cold and all they can find out is your identity, then you sure as hell want them to find out if you have a penicillin reaction problem, for instance. So the purpose is important, but it's also about the efficiency of running a health service and the research agenda that can come off the top of it. I hope that we've moved significant strides forward in the pandemic, because the vaccine rollout was such a success and people saw the value of the NHS understanding a little bit about them, so they could be invited to an appointment, in and out within 15 minutes. And then you could use that in order to travel, and get it on your smartphone on the NHS app.
Efficiencies were great. Yeah,
exactly. And there was a real success story that was very tangible to people. And so in the future, when those running health services, certainly here at the NHS, and I hope around the world, will be able to say to people who are cautious about this, look, it's been done. It worked really well. So let's do it more broadly. For all sorts of other conditions.
Absolutely. I mean, the amount of times patients, they have to fill out this form again. Haven't you got this data? Because they go to a different health point. So the frustrations are extreme. But the simplification of health data collection and making sure that there's the right privacy laws around it. But to take that the next step into genetics, which is a place which I think the future of health is going into, and helping people understand that, yes, there is privacy issues, there's trust around that, and that the data will be managed properly. But that fear, I think, of people looking at a Gattaca equivalent, that sci-fi movie, trying to help people understand the practicalities of, if you have this gene test, you may be able to use this drug and not have a side effect, or you might be able to use a better alternative drug because you are at risk of a side effect, or you've got a cancer, we're going to do your gene screening because that will help, tailor the medicine to you, or even being able to understand that you've got a preventable condition like hemochromatosis, that if you've got one gene change, you'll never get the disease because you just give blood. And if you give blood, that's got a social good as well. So all of these, new things coming at speed in genetic technologies, and helping the consumer and the patients catch up with that. Where do you see that going in the future with regards to digitalisation, then also linked to things like genetic screening and MedTech that's coming online?
Well, I think that genomics is a revolution for the future of healthcare. I think that it won't be long before it is standard to have your genome available. Of course, there needs to be a piece of education and patient care around that, so that people can consent to what they want to know. And people will have to take an active choice. And it'd be totally reasonable to have a default that you don't know anything, and then you can take an informed decision to know the consequences of your genome being sequenced. But I think of it all in part and parcel of the same thing, because ultimately, what is your genome? It is just a very, very, very big data set about you. It's just a chunk of data. It happens to be important and makes us what we are, but nevertheless, you can strip it back, and it's a long string of 4 option.
4 nucleotides.
Yeah, exactly. And so I think that the way that it then plays into healthcare is so important. Now, this is the really hard bit, which is that, of course, where a condition is an automatic result of a known mutation in one element of the genome, in a way, that's the easy bit, because that's there it's automatic. Ending the horrible odyssey of discovery that many people, especially with rare diseases, can take years, if not decades, to find out what is the root cause. You can end that at a stroke with a sequencing of the genome, and then improve the way that they're cared for, what have you. The much harder bit is when genomic mutations lead to tendencies rather than absolutes. I think that's, there's so much that we can do there to improve how healthcare is delivered, but nevertheless, the sensitivity required is much higher because it's not an absolute. But when we properly marry together your genomic data, your experiential data, I wear a smartwatch, many people do, and your data from your health records, that's when we'll truly find the insights that we need to. And we are getting there. There are now hundreds and hundreds of thousands, if not millions of people in the UK who've had their genome sequenced. And for us, the NHS is a great opportunity here, because it's a trusted guardian in terms of the data, and because all of the data, it should and can therefore be in one place. And we're not quite there yet. There's still some records that are on paper that need to be sorted in the.
Oh, I heard you famously wanted to try and eradicate fax machines by 2020.
I know. And I put out a direction saying we're going to end the use of fax. I banned the purchase of fax machines and said we're going to get rid. I saw it recently. There's still 100 going. I mean, they are the worst type of. It's so insecure. What if somebody else just happens to be standing by the fax machine?
Yeah,
it's not just about efficiency, because they're spectacularly inefficient, but it's the data security. I mean, if anybody in the NHS still uses a fax machine, they should get rid of it now. It'd be far better just to send somebody an email on Gmail, or take a photo of the piece of paper and WhatsApp it. That would be.
Or put it on, give it a pigeon carrier.
Yeah, well, I'm not sure about that. But the modern technology is spectacularly more secure than the old technology, and there was this attitude in the NHS. I don't know if it's the same in Australia, that if it isn't invented in the NHS, then it can't be properly secure and good enough for them. And one of the things that we did right at the start of the pandemic was said, what matters is the data security, not the brand. So that opened up the use of, Gmail and WhatsApp and all these services, because, the companies who work on them spend billions of pounds on data security and really care about it. So, it doesn't have to be invented within the NHS to be used by the NHS. I don't know if you have that.
Well, Australia's a much more derivative. We're good at stealing other people's ideas and making them work for us. So we watch the epidemics happening overseas and we act in response. So, for instance, with HIV, we had a really great response because we saw what was happening in the US. I mean, I would argue it with COVID, we're probably one of the few countries that was leading the way in a number of things, which is unusual for us. We tend to follow. And that may have been because we're right in the heart of the pandemic. And most people don't quite realise that our response, because we're in Southeast Asia, was actually quite amazing, because we got onto test and trace. We got onto closing borders early. Yeah. We were actually ahead of the curve. And in fact, when we first talked about closing the borders, there was a lot of international backlash about how stupid we were. And that proved to be probably one of the most decisive things that we did during COVID. And then we also got onto track and tracing very quickly. But talking about trusting data. The US, for instance, didn't trust sequencing from Australia. We were the first to sequence the virus. And so it had to sequence it itself. It's like you said, the NHS doesn't trust information from outside. The NIH didn't trust information from anywhere else. So it sequenced itself. And the COVID test, was incorrectly, the outcome was incorrect, and they ended up being delayed 6 weeks to get COVID testing off the ground to late February before they had a COVID test ready to go. Well, we already had COVID testing in mid-January, I think.
Yeah.
So that's an example of countries not listening to others who are leading the way and not trusting anyone but their own data. But just to move on from talking about the systems, talking about health literacy, and that does follow on, because I think COVID's been incredibly powerful in increasing upskilling health literacy in the population. I'm a public health professor, and people being able to talk about quite complex epidemiological concepts, to me was extraordinary to watch, because as a medical researcher and a paediatrician, we spend a lot of time talking to the media, trying to upskill people's health literacy. And now we had premiers of states and prime ministers and ministers of health speaking to the general population on a daily basis. So it's been an extraordinary opportunity. But if we apply that then to genetics and the genomic revolution coming at speed, do you think there's been benefits of upskilling people so that they can use their own data, whether it's genetic data or, as you say, just other forms of biological data, and that they've become more open to using data and therefore more empowered to be in control of their health?
Yes, is the short answer. I hope it lasts. So just to put a note of caution, I hope it lasts. I introduced the NHS app just before the pandemic for people to be able to engage better with their healthcare, and we didn't know what would drive up user uptake. We thought there'd be maybe 1 million people who were actively enthusiastic about managing their own health through it. But of course, the pandemic led to more than half the population downloading, and that's obviously a good thing. And people have engaged with science like never before. I hope that it lasts, and I hope that people stay engaged. It'll be quite hard to know the extent to which they do, but I think it's important.
Yeah. In Australia, we've, 4% of our GDP is spent on health. By 2040, just because of an ageing population, it's expected to be 8%. And we've got obviously a narrowing tax base as people age and leave work. And so, there's going to be this big increase on spending on health in the future. And that's true for all developed countries, but even more so in the aged care sector as our population ages, and the end of life years are the ones that are the most expensive to the healthcare, but also to aged care. In the UK, how do you see, with more expensive drugs coming at speed, with an aging population, with people expecting higher quality health, are the systems we have in place sustainable? Is the NHS going to be sustainable into the future?
Well, it can be. It is a big challenge because of all the reasons that you set out. So demands increase. The note of optimism is that the new technologies coming down the track have the potential to reduce future costs of healthcare, whereas in the past generation, new technologies, in particular new drugs and pharmaceuticals, increase the cost of healthcare. So that is the opportunity that needs to be seized. Managing the overall cost is hard, right? That is difficult, because when you have a healthcare problem, it matters more than all the money that you've got. And we've managed that with the NHS throughout its whole life. I mean, after all, one of the things that brought down the 1945 Labour government was that when they introduced free glasses and eye tests on the NHS, the demand was spectacularly higher than they thought, because a huge number of people had undisclosed sight problems, that they couldn't afford to get glasses until they were made freely available, and there was this revealed demand. And we've got a problem now of demand that was suppressed during COVID, for good and bad reasons, and is now revealing itself back to the NHS, and hence it's under massive pressure. Managing that is difficult, but I come back to where we started our conversation, which is you can only do that if you modernize the service and make sure that it's efficient.
Well, I suppose, having been health secretary, what would you say would be, your biggest win? What was the day that you went, wow, this has really worked well for me, and I feel like I've made a big impact?
Oh, without doubt, the vaccine program, the rollout of the vaccine, so having the first vaccine in the world signed off and injected in Coventry. I gave the team at the start of 2020, I gave the team a year. They said it'd normally be 5 years, but they thought they might be able to do it in 18 months to get a vaccine going. I mean, you talked about testing early on, and expanding testing was, that was really tough early on, but getting the vaccine, that was the way, that was what got us out of the pandemic ultimately. And it's funny because the Oxford vaccine is well known as the British one. That came second. I didn't mind at all. What I wanted was a vaccine for the British population and ultimately for the world. And I guess tied to that, that Oxford vaccine we made available to the whole world at cost. And there was then this huge debate about the intellectual property of the vaccines and should the companies be charging. And I just looked at it and thought, well, we're miles ahead of you guys. We did this deal a year ago, and now almost half of the vaccines in the world have been the Oxford vaccine done at cost, funded by British taxpayers. I'm pretty proud of that.
Yeah, I mean, I have to say we were, whooping and cheering on our side of the pond, but, it unfortunately became unstuck simply from a political reason. So, AstraZeneca, we knew it was going to be, or the Oxford vaccine was going to be the backbone of the vaccine rollout around the world, because, it was something that Oxford did a deal with you to say, we're going to do this. And I just thought that was an extraordinary gift to the world. And in Australia, unfortunately, the side effects somehow got ahead of us, and we could never really get that genie back in the box. So it was, we had a diversified portfolio of vaccines that we were looking at, including an Australian-based vaccine developed at UQ, which unfortunately resulted in people testing HIV positive in a false positive way, because the vaccine backbone was based on HIV. Okay. So that was rather unfortunate. But we had all sorts of political problems with the AstraZeneca vaccine, which was really unfortunate. But anyway, it was regarded. The standing ovation at Wimbledon was extraordinary.
It came under sustained political attack that was essentially begun by the European Union in a totally unfortunate and unnecessary way. And I had personally insisted on the exclusivity of the first 100 million doses for the UK, and the European Commission were under massive pressure because they were behind the curve. And they decided to try to get through that political pressure by having a go at the Brits and the British vaccine. And it was, I put in the exclusivity deal because I was worried about Donald Trump getting somehow getting his hands on the vaccine and stopping us from being able to get hold of it. I didn't know that I should have been more worried about Ursula von der Leyen, but it was a massive mistake by the European Union that had consequences all around the world in terms of.
Well, in Australia got politicised, and Labor basically got to the point where they're almost saying, if you're a pro-Liberal party, then you'll believe in AstraZeneca. If you're pro-Labor, you'll believe in Pfizer. And I actually stood up on the floor of Parliament and said, shame on you. That is not in the national interest. Those sorts of unhinged and unprofessional comments were driving up vaccine hesitancy. And, everyone looks back and shakes their head and says, what on earth actually happened there? But that's an example of politicisation of healthcare in a very unfortunate way.
That is outrageous. The idea that you can get elected to Parliament on that sort of platform is just terrible. God, I hope you win your seat back.
Thank you. So do I.
It's antediluvian. In fact, we didn't, because it was all done through the NHS, we didn't allow people to choose unless you were under 40. In which case the preference was to have the Pfizer vaccine. But an AstraZeneca vaccine was still better than no vaccine.
Yes.
And this is, I think, what people didn't, don't
well, this is the
understand.
problem for us in Australia, is actually because we had that sort of lockdown approach, which we probably did rather overly enthusiastically. I think in the Liberal-based state, New South Wales, it was done more light-handedly, while in Victoria, the Labor-led government basically seemed to take almost a CCP playbook, and we had the world's longest lockdown, unfortunately, in Melbourne, which has caused all sorts of ongoing healthcare problems, mental health issues, even still today. But it is interesting because the way that the political parties responded, came up with this very different response, and not necessarily, evidence-based, expert-informed, but differences in opinions about how to do things.
Yeah.
And that whole AstraZeneca versus Pfizer ended up confusing people and making them quite angry with government because they didn't know which one that they should choose, and they weren't being given the choice.
Yeah. Wow. Well, I'm glad we avoided that.
Well, it's been fantastic speaking to you. Thank you so much for your time, and look forward to watching your crew with a great deal of interest. You've made a massive impact on the world's health, and rolling out the vaccine and leading that rollout, and shepherding your country through its toughest times. It's been an enormous privilege to speak to you, and I've really enjoyed our time together.
Great pleasure, Katie. Thank you very much for having me on.
Lovely. Thanks, Matt.